Okay, and then hit the orange button to minimize that. And don't forget
this button?
Yes. Don't forget to stop the recording when you go to break.
Okay, how do I do that though? How do I go?
Hit the button again.
Hit that and back and go and then hit recording. Okay.
Yep.
Okay, so I'm recording now, right?
You're recording now. Hello. Say hello to the crew.
Hello to the crew.
Hey, Doc, this is Hollingsworth.
Okay.
Hey, Dr. Whitwer.
You want to give a brief, super quick blip on that. Okay.
Nobody ever listens to me.
Okay, good morning. You know, I have to stand here now because of the camera, because we are recording. We are recording live. So, okay. Quick announcement first. March 13th, P-South Southwest trauma case review open to all medics.
Okay, Joe, let's start.
George Dulabon will be, he's one of the trauma surgeons, will be presenting a case. There'll be breakfast as usual, that sort of thing. Starts at 7:15 to 8:15. All right, today we are going to go into gastro and urology. See if I can get this thing to move here. There we go. All right. General risk factors for both for diseases of the gastrointestinal tract as well as the urologic tract are kind of the same things. Excessive alcohol, smoking, increased stress, ingestion of caustic substances, poor bowel habits, which is a characteristic only of Western civilization, I think, and acute. The thing you should remember, most of the problems that happen in the GI tract, except for acute gastroenteritis by infection, are caused by chronic underlying problems. Same thing with the GU tract. It's a chronic problem. So we're going to see problems in the urologic system that have to do with chronic renal disease, problems in the intestine. GI bleeding usually is occurring from a chronic problem. So it's chronic things. Now, pain from the viscera, described as visceral pain, is poorly localized. It's generally caused by stretch of an internal organ, or inflammation, or ischemia. Internal organs are very sensitive to those sort of things. They're not sensitive as much to cutting and burning, which is kind of interesting considering that in the Middle Ages, that people were, particularly in England, they were fond of doing what was called drawing and quartering. For if you had someone you were particularly ticked off about, they would start to hang you, and then to the point where you were somewhat unconscious, and then make an incision, pull out part of your intestine and crush it, burn it in front of you, which was kind of a nasty thing to do. But interesting enough, that doesn't hurt to burn the intestine. So it's kind of a bizarre process that they were thinking about. But visceral pain is different than somatic pain. Somatic pain is what we usually would consider like musculoskeletal pain. So if you break a bone, that's somatic pain. If you have a big bruise that's painful, that's somatic pain. If you have a stab through a muscle, that's somatic. That's a somatic pain. Visceral pain is dull, crampy, poorly localized often. So a lot of times GI pains are described as generalized. You can't localize it. Once again, inflammation, dilatation, stretch of fibers, and ischemic pain are usually the causes of visceral pain. Now, the little diagram up here shows you where you kind of refer things. As we all know, referred pain, so your brain cannot localize pain from the heart very well. So it generally shows up as in the general left quadrant, but down the arm actually radiates into the right arm often. As a matter of fact, that's probably, I think Dr. Mock mentioned a couple times ago that if it refers to the right arm, it's probably more likely to be cardiac than not. Refers to the neck, to the jaw. Renal colic is often felt in either flank, and we're going to talk about renal colic at a greater extent. It's also then radiates down into the renal and ureteral colic radiates down into the groin. Pain from the gallbladder is not only felt in the right upper quadrant, but also up into the shoulder blade. Pain from the liver is often into the right shoulder blade. Pain from the spleen, we know, refers to the left shoulder blade, left shoulder. Well, obviously, when you approach somebody who may have a GI or a GU problem, your normal paramedic scene assessment, make sure it's safe, look for clues. I always say if you go in, you see a very skinny person laying there with a little pile of vomit in the corner and Karen Carpenter music playing, it's probably bulimia. Identify and treat life-threatening conditions, ABCs. Obtain your history. Mostly, you want to know about previous stuff. You want to know what led up to this, what were the allergies, what medications they're on, etc. Examination of the abdomen. Most of the time we teach you mostly to do visual assessment. You don't do an awful lot of palpation, although the abdomen is certainly something you're quite able to palpate. So general assessment, viewing, vital signs, and then inspection of the abdomen. This case, these are bruising. This is known as the upper one is Cullen's sign. Cullen was actually an OB-GYN who described abdominal bleeding into the skin of the abdomen as associated with, he was mostly interested in this as a sign of extreme ectopic pregnancy and bleeding from the ectopic pregnancy. Now, I'll tell you this much, you could pretty well diagnose that this person was in trouble. If you've got enough bleeding to cause a Cullen sign, you're hypotensive as well, near death. This also occurs, though, with pancreatitis and with intra-abdominal bleeding from other causes, trauma including. Gray-Turner sign, the lower one, is ecchymosis and bleeding into the flanks, also associated with exactly the same things. Could be ectopic pregnancy, could be pancreatitis, could be intra-abdominal bleeding from injury. We don't teach you a lot about auscultation, but it's always worth listening to the, no good emergency physician would not listen to the abdomen as well as palpate it.
Keep talking.
It's not working.
Okay.
If you listen to a normal abdomen, it's not quiet. And of course, we all know that your abdomen makes lots of noises, particularly when you don't want it to. But an abdomen is always making noise, So if you listen to the abdomen and you don't hear any movement of fluid and gas, don't hear any noise at all, that's abnormal. It's always moving. So we listen to see, because if an abdomen isn't moving, it means that it's trying to stop movement of the intestine to not irritate the peritoneum. That's a clear sign of peritoneal inflammation or blood in the peritoneum, which causes inflammation too. So a silent abdomen is abnormal. Now, in obstructions or partial obstruction, you get rushes, you listen, you auscultate, and you hear a lot of noise and then quiet. A lot of noise and then quiet. And that's because it's trying to push past the obstruction. Doesn't generally do it. Then it ultimately goes silent. Palpation of the abdomen, you're palpating for pain directly, and the way to palpate an abdomen, someone is complaining of right lower quadrant pain. You think, oh, maybe it's appendicitis. Don't start palpating there first. We palpate in the left lower quadrant, the left upper quadrant, the right upper quadrant, and then in the right lower quadrant, because if you push on the left side and you say, oh, it hurts on the right side, that's called crossover rebound tenderness or rebound tenderness. If you push on something and it hurts, and we take our hand away quickly, and it says, oh, that hurts worse, that's rebound tenderness. That's a clear sign of inflammation. So that's why we don't do that a lot of times. You don't say, hey, does that hurt? Hey, does that hurt? Once is good enough. You do gentle palpation first, and then deep palpation, and then deep palpation with rapidly taking it off for rebound. That's a sign of inflammation if they have rebound tenderness. Okay, what makes up the gastrointestinal? Well, the upper GI tract basically starts at the salivary glands for all intents and purposes, and because they help to start to digest food, works down through the esophagus. Where the cardia is called where the esophagus meets the stomach, and it's really the diaphragm provides the muscular control at that point. So when someone has a hilar hernia, what happens is the piece of the stomach herniates above that diaphragm connection, and so there's no closure anymore between the bottom of the esophagus and the top of the stomach, so you can reflux acid much more easily. That's why hilar hernia is not a good thing to have. Then, of course, you've got the stomach. Stomach is primarily on the left side, unless you're a reverse person. And then from the stomach into the duodenum through the pylorus, then the duodenum down to right about here, mid-level. The duodenum is probably 12, 16 inches long altogether. And there's a ligament at that point called the ligament of Treitz, Treitz, the German guy. And this thing, and this tacks down the intestine to the peritoneum and to basically to the front surface of the pancreas. And that's a tether point, and that's important because when you have sudden stops, particularly when you flex over a seatbelt, when you run into it, when you're unseatbelted and you flex over the lower edge of your steering wheel as you crash your car, that ligament holds your intestine tight at that point, but the rest of your intestine and internal organs sort of move forward with a great deal of force. That can tear the ligament itself, that can tear the junction of the duodenum, or that can tear into the retroperitoneum and injure the pancreas. And so you end up bleeding out into the abdomen, which is much more easily diagnosed, because then you have inflammatory signs and symptoms when you examine the patient. Or you bleed retroperitoneally, which is more difficult to diagnose because you don't have abdominal pain, abdominal symptoms from that. You have retroperitoneal symptoms. From that point on, at the ligament of triceps, so at the end of the duodenum, then you go to jejunum and ileum, and then it runs. So that's all the small intestine, and there's lots of that, 26 feet or so, give or take. And then you run into the colon. Colon joins the ileum at the ileocecal junction. The cecum is the first part of the colon, and the appendix lives at that spot. Then the colon, which is probably about normally 3.5 to 4 feet long altogether, a lot of gut in there, goes the ascending colon, transverse, descending colon to the rectum and out. Gallbladder, now your accessory organs, liver fills up a great deal here. Both, there's a left lobe and a right lobe. And it's in exhalation, the dome of the liver rises to the level of the fourth, when you're laying down or standing up, rises to the level of the fourth intercostal space. So if you get, as we've recently had, a bullet wound through the lower chest, anything below the nipple line or the fourth intercostal space, you have to assume that there's an intra-abdominal injury as well as a chest injury. So in this particular, and this was the guy who was shot at the vets, took a couple of bullets to the chest, and one went through, got rib, pneumothorax, hemothorax, liver, punched a hole through the liver, punched a hole through the diaphragm because the diaphragm is sitting there, and kept on its merry way, getting more lung through that side. So you get quite a bit of injury that way. Gallbladder lives underneath the liver, connected to it's just a storage organ for liver bile. And then when you eat a meal, a fatty containing meal generally, the gallbladder contracts, squeezes through the bile duct, through the common duct, which also drains the pancreas, and then dumps into the duodenum.
This is
help to digest fats.
a real special thing.
Well, we get called mostly for everything from nausea, vomiting, abdominal pain, and GI bleeding. Most people get very excited when they have GI bleeding. Usual causes of GI bleeding in our society are peptic ulcer disease, simple gastritis, rupture of a varix, esophageal varices, very significant, huge bleeding usually. Mallory-Weiss tear is a tear of the esophagus, fairly rare, usually caused by excessive retching. So it's not associated with severe bleeding unless it's a tear right directly through the through a varix. And then esophagitis, etc. So upper GI bleeding has visceral pain. So it's generally, most things will have general abdominal discomfort. They may be complaining, if it's a peptic ulcer, they may complain of a lot of upper epigastric kind of discomfort, heartburny kind of thing. But most GI bleeding is associated with just general, my abdomen doesn't feel good. It's hard to describe. Hematemesis means vomiting blood. Now, it can be bright red blood, it can be venous type of blood, it can be coffee ground. Coffee ground bleeding means that the blood has been bled or gotten into the stomach, gotten into contact with acid in the stomach, and it changes the ferric ion of the hemoglobin to ferrous, which is brown in color rather than red in color. Melena is, by definition, upper, which is black tarry stool, black tarry blood, by definition is upper GI bleeding always, because it has to have been, in order for the blood to turn dark brown or black, it has to be acted on by acid. So it has to happen somewhere in that point from the stomach, from the esophagus to the duodenum to be melena. If you have bright red blood in the stool, or venous blood in the stool, or currant jelly colored blood in the stool, by definition, it's lower GI bleeding. Now, theoretically, you could have a massive bleed into the upper, to the stomach or duodenum, and so much blood coming out that by the time it gets passed through the anus, it is still red. But that's probably a moot point, because that patient's going to be either, totally shocky by that point to have that happen, or, who cares where it's coming from at that point? Your job is to keep them alive at that point. But melena means upper GI bleeding. Now, if you have enough bleeding, you're going to get signs and symptoms of shock. And a lot of people complain that they're feeling lightheaded. If you sit them up, don't stand them up then. Don't force them to do that. And that's nature's way of telling you that you've got orthostatic vital sign changes, and they're significantly shocking. 2 large bore IVs, volume replacement. Now, obviously a life-threatening issue. Remember, these are almost always some chronic problem. People will have mild GI bleeding that have normal vital signs, and most GI bleeding in most old people is chronic, slow, and you adjust to it, and so they are not going to be significantly shocking. So you're going to be, your test of this, whether this is a life-threatening thing or not, is basically whether the patient has orthostatic changes, whether they have signs and symptoms of shock. All right. One of the biggest causes of esophageal varices, and we've seen a couple cases recently, is esophageal varix. An esophageal varix is caused by increase in portal hypertension. The portal vein drains the gut to the liver. It's bringing all the food products that you're absorbing through your intestine to the liver. Portal vein starts there has a branch that comes from the esophagus, and it ends at the tail vein, which is basically where you get hemorrhoids, because it's the last vein of your intestinal system. All that drains to the central portal system, goes to the liver. When you increase pressure inside the liver, you get portal hypertension. And it does what any vein does when it has increased pressure: it swells. It gets bigger and bigger and bigger. That's why you get, it's the increase of pressure in the portal system that causes the varix. It will accentuate hemorrhoids. I'm not going to tell you that hemorrhoids are due to portal hypertension, because then you'll think that most of us have chronic alcohol abuse and liver cirrhosis, but that's not. We have hemorrhoids because we stand up on our hind legs. And we also have unusual habits of going to the bathroom. And that all increases the pressure in the last vein of your body, which is the hemorrhoidal veins at the anus. They can be both internal and external. More about that later. Chronic alcoholism and liver cirrhosis is the most common cause of portal hypertension, but there are other causes too. I mean, some people have cirrhosis of the liver from hepatitis. They have cirrhosis of the liver from other things other than chronic alcohol. Caustic substances, if you sat and just ate, if you ate battery acid, you would probably burn a hole in your lower esophagus, which will also get into the portal vein. But most of the things that we see for severe esophageal varix bleeding is from portal hypertension from cirrhosis. So they have trouble swallowing, they have huge amounts of hematemesis, and this is generally bright red or venous red bleeding, copious amounts. It doesn't hurt. You have that hole, what happens is that they get a big, if you can imagine, like a huge hemorrhoid, you get a huge vein into the wall of the esophagus, and then if you have some retching, you'll tear across it because it's very weak. Or if you get a little bit of acid reflux, it'll just get a little esophagitis and burn a hole through that. And then once it's got a lot of venous pressure, then it starts bleeding copiously. And there's no way to stop it because the vein can't contract. So it really goes. They get huge amounts of blood loss, classic signs of shock. So you may have to do aggressive airway management because they're vomiting so much blood and they're having difficulty with that. They're getting semi-comatose because of their shock. Aggressive fluid resuscitation, generally two things. And your orders say that if you suspect esophageal varices, so severe hematemesis, patient in shock, suspicion of alcoholism, if you want, or liver failure from whatever cause, that patient goes to PCEP Southwest because the only way we fix these nowadays is to take them to the cath lab and selectively cannulate the artery and the vein and then put in a flocculant, something that clots it, that stops it. It's the only way, just like pelvic venous bleeding from pelvic fractures, the only way we can really effectively stop that is to go in and selectively cannulate those veins and artery that supplies them. Okay, then we get called for acute gastroenteritis. Now, that can be caused by a lot of things: alcohol, tobacco use, chemical ingestions, non-steroidal anti-inflammatories are implicated in that nowadays because these are antiprostaglandins, and one type of prostaglandin, which is produces the protective mucus to protect your stomach. So systemic infections, we see gastroenteritis on a viral basis, on a bacterial basis. So basically, the mucosal GI surface is damaged. You get inflammation and then hemorrhage and erosion. Generally speaking, most gastroenteritis of whatever is associated with vomiting, severe nausea, vomiting, and often diarrhea as well, because it's an infectious and it's kind of generalized to the entire GI system. You can get hematemesis. You vomit enough, you get enough erosion of the mucosal surface, and you'll get some hematemesis. Hematochezia is just a $25 word for blood in the stool. And you can get melena if it was involving primarily the upper GI as well. Diffuse abdominal pain, generally with gastroenteritis. I mean, we've all probably had viral gastroenteritis, and you get sort of generalized abdominal crampy pain. Classic signs of shock can occur if you lose enough. You get shock on the basis of a little bit of blood loss, but mostly it's fluid loss. Nausea, vomiting, diarrhea. Fluid replacement, general treatment guidelines, treat them for shocky things, treat them for dehydration. If they're nauseated, antiemetics. Now, some people have chronic gastroenteritis, long-term mucosal changes, and it's usually bacterial caused, usually more frequent in third world countries. And you just once again, treat what you find. Peptic ulcers, generally speaking, caused by erosions caused by gastric acid when the mucosa of either, and these can occur in the esophagus from reflux of acid, sometimes associated with a hiatal hernia, sometimes associated with just a weakness of the cardium, which is where the diaphragm makes essentially a sphincter at that point. It can occur in the stomach. It's a true gastric ulcer then. And because there's a lot of acids getting through into the duodenum, it can occur in the duodenum. So you have a duodenal ulcer. Generally speaking, though, their peptic ulcers are just occurring in the lower esophagus, stomach, and duodenal ulcer. Increased when you have ibuprofen or other non-steroidal anti-inflammatories because of the suppression of that protective prostaglandin. Alcohol and tobacco use increases it. And in about 40 to 50% of the cases, we find a bacteria called H. pylori that's made enough of a systemic infection that you can now we don't have to find them. Used to look for the bacteria in stomach. You try to grow it from stomach cultures, but now we just do an antibody test, basically, and you can test and see that if you've got an antibody to H. pylori, by definition, you've had an infection with H. pylori. So about 40 to 50% of peptic ulcers we treat with antibiotic to suppress the H. pylori, and the patient gets better. Now, I'm not sure that's a particularly. I'm not sure that proves that it was H. pylori, because treating peptic ulcer is very most people get better when you diagnose it, no matter what you do. We treat with antacids, we treat with bland diet, we treat with the new H2 blockers, things like that, and proton pump blocking drugs. But no matter what you do, people usually get better. There was a great study years ago where they fed half the people with, it was a military study, we didn't get away with this sort of thing. They fed half the people with peptic ulcer bland diet and half the people Mexican food, and they all got well at the same time. So go figure. Peptic ulcer usually has abdominal pain. Usually it's epigastric pain, non-radiating. If they have sudden severe, now sometimes a peptic ulcer will actually erode all the way through the wall of the stomach and you perforate. When you perforate, of course, then stomach acid rushes into the and food products rush into the peritoneum, and it causes extreme pain and extreme inflammatory symptoms, usually shock as well. So pain, Hematemesis, and this is where you get the coffee ground kind of emesis because the blood's been acted on by the stomach acid, and black tarry stool, melena. Treatment, so ABCs, treat for shock. If they have severe pain, give them pain medication. If they have nausea, that's making it worse because as they retch, that'll increase pressure in the stomach and can encourage the perforation. So treat them for pain, treat them for nausea and vomiting. Okay. Lower GI bleed, bleeding distal, so past that ligament of Treitz, right in the middle. So it's in the bigger part of the intestine and also in the colon. Usual cause, the most common cause in the United States and Western world of GI bleed, lower GI bleed, is diverticulosis. Little outpouches in the colon. There are other colonic lesions that can cause blood. Rectal lesions, particularly hemorrhoids, are real common. And then there's some inflammatory bowel disorders, ulcerative colitis and Crohn's disease that we'll talk about. So, once again, is this acute or chronic GI bleeding? It's established by history and your vital signs. Color of blood in the stool, the higher it is in the intestine, the more it's going to be sort of maroon in color. The lower it is in the colon or in the intestine, the more likely it's going to be bright venous red to bright red. Abdominal pain from lower GI bleeding is generally not very localized. You can often localize it by palpation, but the patient says, I kind of hurt all over. Obviously, signs of shock if they have significant GI bleeding. IV access, large bore catheters, treat what you find, treat for shock. So, ulcerative colitis, interesting inflammatory bowel disorder. We don't know the exact reason for ulcerative colitis. Seems to run in families, so there's probably a genetic connection there. Seems to, it may be related, however, to allergy, to some toxin. Definitely has psychological things. Almost every patient who has ulcerative colitis, if they're under stress, they have the risk of having a flare-up of that disease. It's an inflammatory bowel disorder. You get recurring bouts of bloody diarrhea, and because it's involving the colon, it's generally red blood, venous bloody diarrhea, and stool, mucus in the stool. It's colicky, crampy abdominal pain when you have the flare-ups. It's associated. You have nausea and vomiting when you have a flare-up. So this is a recurring inflammatory condition. Generally, they sometimes will have a fever associated with it, although they don't really have an infection. They will have a fever because it's inflammatory. Severe cases, depending on how much bleeding and how much diarrhea they have, of course, could have shock. Management is, once again, it's the beauty about emergency medicine and paramedicine is you treat what you find. If they're shocky, treat them for shock. They may need a fair amount of fluid. If they're nauseated, treat them for nausea. If they have abdominal pain, you may give them pain medication. Narcotics are real good anti-spasm. The initial in the old days, the only thing we had to treat abdominal cramps were narcotics. Cramp eating, the only thing we had to treat. And to this day, basically things like Lomodal, loperamide, the anti-diarrheal, antispasmodic diarrheal medications are related to the opioids. They're basically narcotics. So if someone had severe abdominal cramping, I wouldn't hesitate to give them, as long as they're not shocky, I wouldn't hesitate to give them, small amounts of fentanyl. If you're treating pain, it's going to treat pain. Crohn's disease is another inflammatory thing. It's another one of those idiopathic things. We're idiots, we don't know the pathology. Now, Crohn's disease versus ulcerative colitis, Crohn's disease can infect the entire GI tract. So it can be small bowel as well as large bowel. And the pathologic inflammation, chronic inflammation, damages the mucosa. You get fibrosis and hypertrophy of the muscle underneath this, particularly in the lower intestine, which has a lot of muscle. You get fissures and fistulas. You can get a fistula passing from one part of the small bowel to the other, to right straight through. Inflammatory bowel walls stick together, and you get a fissure between the two things. So you get a short pathway. Patients can have GI bleeding, nausea, vomiting, diarrhea, often associated with fever because it's more of an, because of these fistulas, they can get abscesses, they can get much more likelihood for infectious things. Weight loss, you're going to treat what you find. Diverticulosis is the underlying condition. Diverticulitis is an infection in a diverticula. Diverticula are little outpouch. The colon, diverticula only occur in the colon. The colon is an unusual organ in that the rest of the intestine has muscle entirely around it, encircling it. So the muscle squeezes, and that's normal peristalsis, and food moves along. In the colon, the muscle is, there are three bands of muscle that go along, just track along the colon, and when they shorten, they sort of pull the colon together, and that's what makes things move in the colon. But it's a much more bigger storage, and in between these bands, the three bands of muscle, the mucosa is fairly weak. So if you increase the intraluminal the pressure inside the colon, the mucosa has a tendency to bulge outward like a balloon, and like a balloon, you can get a weak spot that balloons out quite a bit, and that makes the little out pocket, which is a potential then place to store for things to pack up. The colon is the primary water absorbing portion of the intestine, and as such, it develops a fair amount. Things dry out, relatively speaking, and you get quite a bit of gas, and that's what increases the pressure inside the colon. Now,
Mute your mic, please. We don't want to hear your cat or kids or whatever that is.
I'm not hearing anything. So anything that increases the pressure inside the colon will encourage the formation of diverticula. Now, with our diet, we get Western diet has a tendency to be gas forming, produce a lot of intestinal distension. It also has we also have a tendency to have kind of poor bowel habit. So diverticulosis is pretty much a disease of the Western world. Also, we have relatively low fiber diet. And I hear the kids now. and in our society, in the United States, probably 40 to 80% of persons over 40 years of age have diverticulitis. Diverticular, not a real big problem unless you can get bleeding you can get venous bleeding into diverticula, not associated with diverticulitis. But if you get stool packed into the diverticula, sometimes the diverticula can get inflamed. Then because it's a very weak, thin mucosa at that point, that passes very quickly to inflammation of the peritoneum. You can also get an abscess because you leak through this weakened diverticula. So you get abscesses, you get inflammation of the diverticula, you get diverticulitis. Diverticulitis then can erode into a vein, even a small arteriole, and cause significant abdominal bleeding. It's the most common cause of acute GI bleed in the United States is acute lower GI bleed. Now, signs and symptoms of diverticulitis are abdominal pain and tenderness. If they have an abscess, you'll localize with rebound. Usually it's in the left lower quadrant, not the right lower quadrant. Because the biggest chance of having diverticula is in the descending and transverse colon, not in the ascending colon, the first part of it. Fever, because it's an itis, it's an inflammation, it could be an infection. Fever, nausea, vomiting, sometimes GI bleeding. Now, you can get significant GI bleed from this, particularly if you get an artery eroded. Obviously, you treat what you find. Hemorrhoids, most common cause of bright red bleeding and painful, along with pain when you have a bowel movement. That's lower GI bleeding. Bright red, almost arterial red looking. So you'll have blood in the toilet, blood on the toilet paper. That's the questions you ask them. I'm always amazed. I ask people, I said, well, is there any blood in the stool? I said, I don't know. I don't look. Is there any blood in the toilet paper? I don't know. How do they know they're done? So if blood is mixed with the stool, it's above the level of the hemorrhoids. If it's coating the stool or floating in your toilet, it's probably hemorrhoidal bleeding. And that makes people feel a lot better if you say, well, it's just a hemorrhoid. It's not, you don't have cancer. Amazing number of people come in and say, I had a little blood in my stool. I'm sure I've got cancer. No, you don't. But it's always worth checking, I suppose. Generally speaking, we don't have to treat hemorrhoids. Now, you're going to get called for hemorrhoids for bright red bleeding that almost always stops after they have the bowel movement. Or you get called because they have pain in the rectum and anus because the hemorrhoid is thrombosed. And that's what people really don't like, is because the blood moves very slowly, the hemorrhoid it'll clot. The blood will clot in the hemorrhoid, and then that causes inflammation, but it also causes extreme pain because the vein doesn't like that. And so we treat that pretty simply a reason, but that requires a trip to the emergency department. They don't have to go by ambulance for a thrombosed hemorrhoid. Okay, bowel obstructions. Bowel obstructions occur when you block the hollow space of the small or large intestine, either completely or partially, and it can be done from a number of causes. There's a picture here of what's called intussusception. Intussusception occurs generally at the extremes of age. So little kids, babies to infants, and older persons. And it requires a very mobile, very patulous type of bowel, maybe with a little preliminary gastroenteritis. But what happens is you get a focal point in the intestine, usually small intestine, that maybe is edematous. And it gets sucked inside by normal peristalsis. So that's why it only occurs in the small intestine, gets sucked inside. And it's the best way to imagine is like when you reach inside, when you're putting your socks together, you reach inside a sock and you pull it inside out. That's exactly what happens to the bowel. So a piece of the bowel creeps down inside itself, begins to flip inside, and then it's now blocked, it's stuck, and it starts to get edematous, and it squeezes itself off, and it has ischemia. So you get pain from ischemia, crampy pain. The bowel is trying to free itself up, and if you stay there long enough, it's going to kill the bowel that's trapped because it's so ischemic. But as this ischemic edematous bowel is trapped, it'll start to bleed from the mucosal lining into the intestine. So they will start passing generally what's described as a jelly-like stool that's current jelly. So it's a deep, dark maroon red color. Obviously, that has to be fixed quickly. The best thing about this disease is that the diagnosis is also the cure, because we diagnose it by, first of all, you have to suspect it, and then you do a barium enema, pushing the barium backward. And as the barium goes through the intestine, it pushes it right side out again. So you not only diagnose it, but you treat it. Obviously, what you have to do is bring them in, and we have to sort out. You have to mostly think that this is not normal for a little kid to have abdominal pain and current jelly stool. Hernias come in all sorts of different flavors, but most of the things we see in males, though, are inguinal hernias, and in either form, the direct inguinal hernia, you herniate a piece of bowel down through the passageway that was anatomically produced when, as you were about 7 months in utero. The male testes descend from the level of the kidney down through the abdomen, dragging the nerve and artery and vein along with them down through a potential pathway that goes through the muscle, between the muscle layers, down into the scrotum. That closes over, then the muscle layers close over normally, but in some of us it reopens under pressures, under stresses, under strains and things, and it then has the potential passageway for a piece of bowel or a piece of amendum or something to get down inside that canal. If it gets down and the bowel gets trapped, that's called an incarcerated hernia. Most hernias are not incarcerated, they just simply have a defect there. We fix them because we're worried that if the piece of bowel gets in there and gets twisted, it gets trapped, and then that's a dire emergency. And that could cause ultimately, if that wasn't fixed, it could cause death. A direct inguinal hernia is basically an indirect hernia, rather, is a tear through the muscle. That's what we get when we say you have a strain. You did something hard, and you get a tear through the muscle, and you can. It's not a defect in that potential space. It's an actual space through the muscles, and you can do the same thing. Get a piece of bowel stuck in it. There are internal hernias that occur inside the abdomen. There are femoral hernias that can occur, but they're a little bit less likely. The most common cause is a direct or indirect inguinal hernia. Women can get inguinal hernias, but it's more rare than males. Volvulus is a twisting of the bowel on itself. Generally speaking, occurs in the colon, occurs in older persons. Generally speaking, if you see an old person with from a nursing home laying there with a distended abdomen, very tight tympanitic, and obvious signs and symptoms of a bowel obstruction, the bet is it's a volvulus of the transverse colon. What happens is it's so mobile, so patulous that it'll turn on itself and it starts twisting like a balloon animal. Of course, then the balloon part is trapped. It's ischemic. It begins to swell. Get edematous, that makes it more ischemic, and then it sort of blows up with gas and pressure, and that has to be unwrapped to make the bowel okay. So that's an emergency. You take them to surgery. Adhesions occur when you get an inflammatory process occurring inside the peritoneum. You can get an adhesion from the stomach to the small bowel, to the stomach to the larva. Most adhesions occur between bowel loops. It occurs after you have an inflammatory infectious process that causes leak of blood. That's why we clean people out when they have a big internal bleed from like a ruptured spleen from an accident. If you're going to take the spleen out, you also try to get as much of the blood out of the abdomen as you can, because that will produce adhesions. Adhesions occur after surgery, even under the best of conditions. Some people make really good scars, really good, so they get adhesions easily. Pelvic infections can cause you to have, so PID, pelvic inflammatory disease, can cause you to have adhesions between the tubes and the bowel, and a place to get, basically the bowel can twist around this adhesion and become ischemic. Abdominal pain, nausea, vomiting, poorly localized. Hemodynamically unstable. If you get free air inside the abdomen with a bowel obstruction, you get peritonitis from spillage of bowel content into the intestine, peritoneum. And your bowel sounds typically in bowel obstruction are first rushes with quiet periods, rushes with quiet periods, and then quiet as you have peritonitis. You treat what you find. Treat for shock, treat for pain. If they're in shock, you obviously can't give them pain medication. Accessory organs of the abdomen: liver, gallbladder, pancreas, and appendix. And the accessory organs will have to wait for about 5 to 7 minutes, okay? Okay, we left off starting to talk about accessory organs. Accessory organs include the liver, the gallbladder, pancreas, and the appendix, also known as the vermiform appendix. Appendicitis is inflammation of the appendix. Most common age group for appendicitis is children. The sort of the epidemiologically the average the age is about 7 to 9. Young adults also are at risk, of course, but I've seen appendicitis in 80-year-olds as well. I mean, appendicitis can occur at any time. The basic problem with appendicitis is you get food and things stuffed inside the appendix, which is a blind pouch, when it gets packed in here, it's not so much that it's an infection as that it just gets packed and it gets edematous and then begins to become ischemic and then the mucosa begins to leak. And when it leaks the contents of the appendix into the surrounding area, and it can actually burst. And then you get a lot more of that content, and the contents, of course, have bacteria, pre-stool, all sorts of stuff, and stomach, intestinal contents into it, and you get an abscess, and you can get severe peritonitis, and peritonitis can cause severe shock and death from an intra-abdominal infection. Starts out as diffuse colicky somatic pain. Most people say that it's periumbilical, so they have pain in the mid-abdomen. If you palpate the abdomen, they seem to have some vague discomfort in the umbilical area. It's not until you start really developing some peritoneal sign that you can localize it to the right lower quadrant. It's localized in what's called McBurney's point, or McBurney's, he was a surgeon, obviously, and described this spot, which is just above the junction between the top of the ilium and the pubic bone. There's a line across there about mid-level, and that's what's the right lower quadrant is McBurney's point. Now, appendicitis localizes to the right lower quadrant in about 35% of the cases. It means it localizes other places or doesn't. I've seen appendicitis present as flank pain because you have an appendix that's very, very posterior, and it actually irritates the retroperitoneum rather than the anterior peritoneum. Most of the time, when you get called, you'll have nausea and vomiting associated with it, low-grade fever, perhaps the patient won't be hungry, and they do not like to move the abdomen, because one of the signs of peritonitis is you try to get a position of comfort and don't irritate the appendix with any movement, or the peritoneum with movement. So that's where you likely will have rebound tenderness. You push on the right lower quadrant. It says, does it hurt? Yeah, it hurts. And you take your hand off very fast and you get that rebound. That's a peritoneal sign. And nine times out of 10, that means you've got an appendicitis. Now, cholecystitis is inflammation of the gallbladder. Cholelithiasis is gallstones. Now, you can have cholelithiasis and cholecystitis. You can have both together because the gallstones can cause inflammation. The usual pain from cholelithiasis, though, occurs when the gallbladder contracts and pushes the stone, which is just the liver bile, it becomes so concentrated that it precipitates out as a salt, and you end up with a stone. If the stone is big enough or small enough, it'll pass down the down the gallbladder of the duct and the common duct. If it's too big, it'll get stuck in the duct, and then you get severe pain as the gallbladder continues to try to contract to push that stone out. That causes a lot of pain from distension, and from distension of the duct itself. That causes pain from the gallstone. Cholelithiasis is just an inflammation, and so you get that dull, colicky, crampy pain in the right upper quadrant, or perhaps up into the right shoulder blade. You can get cholecystitis after associated with diabetes. So there's no stones associated with diabetes, associated with sepsis, associated with burns. Chronic cholecystitis is a bacterial infection, just like any chronic itis. Right upper quadrant pain. Murphy's sign is when you palpate the abdomen. Normally, you can't feel in a normal person, you can't feel the gallbladder or the liver edge at the edge of in the midclavicular line, at the just under that last rib. You have the patient take a deep breath, and as the gallbladder, if it's inflamed, as the gallbladder comes down, it bumps into your finger, and it causes severe pain. That's Murphy's sign. Nausea, vomiting. Cholecystitis generally is associated with nausea and vomiting. Now, the classic history of gallstone, trapped gallstone, is the patient has a fatty meal. So typically come home, eat a pizza in the evening, go to bed, wake up an hour later with severe right upper quadrant pain and maybe some radiation into the shoulder blade. That's sort of a classic history of gallbladder disease and gallstone. Gallstones, because what happens is that as the food goes through, as the fats and stuff from the pizza pass from the stomach into the intestine, your gallbladder contracts to try to squeeze liver bile into that for that fatty meal, and that's when the stone gets stuck. The stone either gets stuck at the neck, where the gallbladder starts into the common duct or into the duct, or at the common duct. And if it gets plugged in the common duct before it goes out into the jejunum, then the liver bile and pressure backs up into the pancreas as well, and then you'll end up getting pancreatitis associated with, and that causes severe upper abdominal pain and radiating through your back generally. Treatment for gallstones or gallbladder, if you suspect it's cholecystitis or cholelithiasis, is treat the nausea and vomiting and treat the pain. And fentanyl is a perfect drug. Morphine used to be a bad drug for a lot of people with gallbladder pain. Would get worse pain if you gave them morphine, because it caused the common duct sphincter to spasm a bit, and that increased the pain usually. So fentanyl doesn't do that. So it's a good drug for this. Pancreatitis, inflammation of the pancreas, can be caused from a lot of things. A lot of times, alcohol abuse we see causing acute pancreatitis, gallstone pancreatitis I just mentioned. People with hyperlipidemia are at risk for pancreatitis. Certain drugs will cause pancreatitis. Certain infections will cause a low-grade pancreatitis, such as mumps will cause a low-grade pancreatitis. Diabetes, highly associated with pancreatitis. A lot of times your ketoacidotics start out complaining of severe abdominal pain mild to severe abdominal pain and pain into their back, and there's because they've got a mild pancreatitis going along with their. Usually they have hyperlipidemia as well as diabetes and elevated glucose. Pancreatitis is generally epigastric pain, often with abdominal distension, nausea, vomiting. Of course, we will have evidence that that the pancreatic enzyme levels are increased because they're not getting out, they're getting into the serum instead. Severe pancreatitis presents generally as hypotensive shock. Now, you can both from blood loss, because sometimes severe pancreatitis is associated with Cullen's and Gray Turner sign, so they have intra-abdominal bleeding. They'll have a DIC kind of phenomenon. They'll have a loss of blood. And because of the nausea and vomiting, and they'll usually have diarrhea associated too, they'll have hypotensive shock. They get respiratory failure often on the basis of this severe hypotensive shock. You treat what you find. Treat them for shock. Hepatitis. Injury to liver cells, usually due to inflammation or infection. So, alcoholic hepatitis, you can get acute alcoholic hepatitis or chronic alcoholic hepatitis. Either way, the liver cells are injured. The liver cells are detoxifying your blood and doing a lot of good things for you. So when you don't have them, then you miss that. Viral hepatitis comes in several flavors we'll talk about in a minute. Trauma can cause hepatitis due to scarring, and portal hypertension itself can cause hepatitis, and it's caused by hepatitis sometimes. Oh no. Well, that's an interesting one, Mark. Well, not sure how to get out of this one. Wine surprises too. Hepatitis.com. Huh. Did he leave, or we got him out there? I clicked ahead right to wine surprises. Oh yeah, wait a minute, let's see. That's not working. I have no idea either. What?
Close it, hit the X, down. Here, give me a
I can't see an X.
Okay, I think we can fix this real quick. I think it just went to a link.
Yeah, it linked.
And it logged out.
I think you probably have to close it and go to another. That's good. There we go. Yeah, that was scary. Okay, hepatitis. Viral hepatitis, most common. Hepatitis A is the classic infectious hepatitis. It's spread by fecal oral route, self-limiting. The incubation period is about 2 weeks, and it lasts about 2 to 8 weeks. Generally very mild, generally very self-limited, very, very little. The worst thing about it is people are fatigued and they can't go to work. And they're also contagious during that 2 to 8 weeks. Hepatitis A, the best thing that's happened to hepatitis A in this country was the invention of the dishwasher, because that stopped the vast majority of intra-family hepatitis A spread, because it sterilizes dishes, disinfects dishes. Hepatitis B is serum hepatitis. Serum hepatitis is spread by body fluids, So it can be by blood, by semen, by not by saliva, interestingly enough, or not significantly by saliva or tears. It's normally a very mild disease, but many people become chronic hepatitis B carriers then, and it can also cause, unusually, it can cause severe liver ischemia, necrosis, and lead to cirrhosis. So it is not a good thing to have. Hepatitis C, mostly through blood transfusions, although there is some risk to, if you don't have a history of IV drug abuse, you don't frequent prostitutes, male or female, and you have not had a history of blood transfusions, and you're an EMT or paramedic, and you come down with hepatitis C, that's considered prima facie evidence that you have this as an on-the-job exposure. It's less risk than from hepatitis B, but it's still there. Hepatitis C, we have no vaccine for. We can treat hepatitis C. So some people with hepatitis C with medications have now become hepatitis C free. The problem with hepatitis C is it will, in chronic hepatitis C, leads to the formation of hepatoma, which is a liver tumor, which sometimes is malignant. Hepatitis D is a hanger-oner, and it's dormant until it's activated by regular hepatitis B. Hepatitis E is waterborne, just like hepatitis A, but so it's a water spread rather than fecal-oral spread. Hepatitis G, it's just there. It's a super infector. What do you get with hepatitis? All hepatitis presents is right upper quadrant, abdominal tenderness and fullness, and generally enlargement of the liver. You can normally not palpate the liver. You can palpate the liver in people with hepatitis. Weight loss, loss of appetite, malaise, clay-colored stool, jaundice, and sclerolectrus. This is because your liver is not able to process hemoglobin to bilirubin anymore, to the bilirubin that goes out in your liver bile, and that's what makes your stool brown in color, is liver bile. So it cannot produce that kind of bilirubin anymore. It produces a bilirubin that's only soluble in the serum. So the serum level of bilirubin rises, and that's what makes you turn jaundiced. That's what makes you turn yellow. Jaundice is also associated with itching. Generally speaking, they itch. They're nauseated because it causes nausea and vomiting. Photophobia because bilirubin reacts to light and causes irritation, so the eyes become irritated in light. Generally speaking, you won't get called to treat somebody with hepatitis, but you will get called there because they'll have sclerolectrus, they'll be fatigued, they'll be nausea, vomit. Treat them for that. Obviously, we can vaccinate for B. All of you should be vaccinated against hepatitis B. It's totally protective. Type A, you can get vaccinated for it. It's not required by OSHA, so it's up to your own hook if you like that. I got vaccinated for type A only because I like to eat raw oysters, so that's, and that's one of the spreads of hepatitis A. You have a question? Is there a question back there, or just an arm up against the wall? Arm up against the wall. Okay. All right. So we're going to go fairly rapidly through the urinary system. Urinary system helps you to maintain normal blood volume, normal amounts, proper balance of water, electrolytes, and pH. It is the kidney is the primary adjuster of your pH. Now, we rapidly adjust pH by changes in our CO2. That's the quick adjustment system. That's the quick one. But for everyday long-term use, your kidney is what keeps your pH normal, the acid-base balance. Kidney also removes certain toxic wastes, some of which are pre-set up by the liver. The liver removes toxic waste too, but the kidney is the next biggest remover of toxic waste. Maintains arterial blood pressure through a number of mechanisms and controls red cell blood development. Big kidney itself has the hilum, which is the central area here, the medulla, which is where the actual function goes on, and within the medulla are the little papillae, which is the beginning of the drainage system, and drains down to the renal pelvis where the vein, artery, and ureter come in. This is all retroperitoneal. They're hung in the mid back. The actual action of where the kidney functions is at the level of the nephron, and you get the glomerulus, which is a little compact package of arteriole and venule surrounded by a thing called Bowman's capsule. And Bowman's capsule is a membrane that becomes the beginning drainage system of the nephron itself. So it makes what's called the proximal tubule. So that you have this little package of arteriole and venule, and of course there's passage of fluid by diffusion and osmosis between arteriole and venule, and of course then the arteriole becomes the venule at this point. So this begins to exude fluid containing electrolytes, containing glucose, containing anything, and it's trapped by the Bowman's capsule, which the internal portion of Bowman's capsule is the beginning of the proximal tubule. The fluid, which is then just a transudate, travels down through the proximal tubule through a thing called the loop of Henle, which is, this is, if you've done any work with HVAC, you can see this is a reverberating system where you get the possibility of movement of fluid and electrolytes and things in and out of this tubule. Then you have the ascending loop, and then the distal tubule, which is also part of this whole system, which is semi-permeable membrane. So absorption can occur along this entire length of stuff. And as you work your way down through this, what starts as a transudate, then acid, hydrogen ion begins to be selectively transported into the inside of this. Water starts to come out. Water comes out at this level here. There's big concentration of glucose, but it is actively transported out of the descending and ascending loops by facilitated diffusion. And urea begins to be pumped into it. Urea is a waste product of protein synthesis and breakdown. Potassium is selectively moved in. Sodium is selectively moved out by active diffusion again. And the concentration of the urine becomes more and more concentrated then, and you're working against an osmotic barrier, so it takes energy to do it. So it's all done by facilitated diffusion and the expenditure of energy, ATP. The filtration of the glomerulus itself, we we do some testing, and we check that out as the glomerular filtration rate, and that just is you have to have some laboratory do. But the normal glomerular filtration rate, you have normal production of urine is at least 30 cc's per hour. If you drop below 30 cc's, you're in trouble. Most of us are producing urine at an average of about 50 to 100 cc's an hour. Reabsorption and secretion in the tubules are by simple diffusion and osmosis, and also by facilitated diffusion, particularly things like glucose and the transport of sodium. Now, the tube, ascending and descending loops, handle water and electrolytes. And of course, diuresis means increasing production of urine. Antidiuresis is retention of water. And that's controlled at the kidney level by antidiuretic hormone primarily. Glucose and urea. Glucose is secreted into that beginning, by simple diffusion. You have a lot of glucose on one side, it's diffused in there, and then it's reabsorbed by active facilitated diffusion and reabsorption. Urea is excreted to replace the glucose. Now, we check this out by not only the level of glucose in the urine, because you shouldn't have, glucose begins to spill into the urine when you have a blood glucose of about 180. You can't keep ahead of it by normal reabsorption. We check what's called the blood urea nitrogen and the creatinine level. That's what the tests we do of basic liver function, chronic liver function. We check BUN and creatinine in the ER, particularly if we're going to give a patient something like a dye study for a CAT scan dye study, because this is excreted into the kidney, and if the kidney is not functioning well, this could become renal toxic. BUN and creatinine will, if they're elevated in their levels of the urea in the serum, that shows that we have kidney disease, chronic kidney failure. Arterial blood pressure is controlled by the kidney. If the kidney senses that you have a decrease in arterial pressure, decreased flow into the kidney at the glomerulus, it secretes renin. Renin then acts on angiotensinogen, which is a precursor that makes angiotensin. Angiotensin increases blood pressure, and by increasing blood pressure, theoretically will drive blood to the kidney. That's the normal thing. It doesn't work if the problem with the blood flow going to the kidney happens to be atherosclerosis or something like that. And then it also increases it by increasing catecholamines, basically, and then it also increases production of aldosterone, which also raises your blood pressure. If the kidney senses decrease in arterial oxygen saturation, it interprets that as being low amounts of red blood cells. It secretes erythropoietin then, which is a hormone that goes to the bone marrow and says, make more blood. So kidney disease affects a whole bunch of your normal homeostatic functions. Now, kidney disease can be caused by inflammation, immune-mediated disease, infectious diseases, physical obstruction, or hemorrhage. I'm going to pop through these because I don't think they're very interesting. Now, acute renal failure. We talk about that a lot. ARF, acute renal failure. That is sudden drop in urine output to less than 400 to 500 cc's per day, so less than 30 cc's an hour. So the patient complains that they're not making much urine. Now, many patients in that condition don't complain. They just happen to be, and you're not with them to tell long enough to know that they're making 40 to 400 to 500 cc's of urine a day. So other symptoms of acute renal failure. And acute renal failure occurs either before the kidney, at the level of the kidney itself, within the, dysfunction within the glomerulus and the tubule itself, or after the kidney. So pre-renal failure, the most common cause of pre-renal failure is you're not getting enough blood to the kidney. And that can be from cardiac failure, myocardial infarction, congestive heart failure, severe hypovolemia with hemorrhage, and that's the thing we worry about with hemorrhage from, hemorrhage and shock from any cause, but particularly from trauma, is that if you don't replace that, if you don't get their blood pressure up to get enough flow to the kidney, because selectively the kidney is shut off, it'll, for the immediate time period to save your life from acute hemorrhage, kidney flow decreases. So you want to get kidney flow back up so that your kidney doesn't die, ultimately. Renal artery stenosis, thrombosis of a artery can cause acute pre-renal function. But the most common cause that we're going to see of pre-renal acute renal failure is hypovolemia, hemorrhage, or cardiac failure. Renal acute renal failure can occur from immune-related disease, the vasculitis, so there's damage within the glomerulus itself, within that arterial, and used to be the most common cause of acute glomerulonephritis was strep infection. That's why we treat your strep throat with penicillin, because untreated strep infection will go away. Your strep throat will get better no matter whether you get penicillin or not. Your strep throat will go away. But if you get beta hemolytic strep causing the strep throat, a certain number of people develop an autoimmune allergic response, if you will, to the strep and kidney combination, or the strep and cardiac combination. So they get either scarlet fever and ultimately infection and actually allergic inflammation of the valves, so they get valvular disease, or they get glomerulonephritis, which is autoimmune immune disease of the glomerulus. And then you get acute renal failure from that. Tubular cell damage, toxins usually, or ischemia, so the tubes are injured themselves. Another way you can get tubular damage is by getting crush injury and getting your tubes plugged up, if you will, with hemoglobin and or myoglobin from the crush. We've seen that a few times in this community. Acute pyelonephritis and infection of the glomerulus will also cause problems. Post-renal acute renal failure is almost entirely caused by obstruction, either of the ureters from stones or blood clots, once again from trauma, or obstruction of the bladder neck from prostatic hypertrophy or stones or tumors, or obstruction of the urethra, which is less common, usually due to infection or stones. With acute renal failure, your focus history is on changes in urine output, if the patient is able to tell you, swelling, generalized swelling face, hands, feet, or torso. So it's not associated with it's not dependent edema, this generalized swelling, because it's retention of salt and water acutely. Heart palpitations or irregularity, changes in mental function. So mental status changes, hypertension's also often associated with acute renal failure, tachycardia, hyperkalemia. This is peaked T waves. Now, I want you to look at this kind of closely because it's acute, it's hyperkalemia, it's going to affect the EKG universally. So you've got peak T waves in a lot of leads, including even in AVR, which it's upside down, of course, which is the way it's supposed to be, but that's pretty peaky. This is really nice peak T waves, but you really basically have peaked, very sharp peaked. That's what I mean, peaked. Sharp T waves in all leads, or as many leads as you see. Now, obviously, you don't see them in this one because it just happens to be the characteristic of the way that lead is being looked at. But peak T waves. Then this is pretty early hyperkalemia too, because as you go out in hyperkalemia, as you get more and more hyperkalemic, your P waves are going to totally disappear. Your QRSs get a little bit wider and begin ultimately forming sinusoidal pattern, and the T wave begins to flatten out at that point or disappear totally. Here's the edema, hands and feet. You may have abdominal findings. They may have acute pain over a kidney, either from infection or from a stone causing acute pain in the flank. IV access, but obviously one of their problems is they've got too much salt and water retention at that point with that edema. So you're not going to dump fluids at them unless you're getting them at the very late end of things where they might be shocky. So all you're doing is keeping IV access. If they're on a nephrotoxic medication, and there are a number of them, we would, take them off medication. That's usually not an issue for you. Now, chronic renal failure versus acute renal failure is just a long-term of the same thing. Permanent loss of the nephron so that they don't adjust all of the things that there's to do. This shows just dependent, this shows edema, pitting edema. This stays for a long time after because this is a transudative fluid again, and it approximates serum so that it'll maintain the fluid and maintain the depression for long. You squeeze it out because it takes a while to get back in. Usually the causes of acute renal failure are just the same thing, either glomerular injury, tubular cell injury, or actual injury to the nephron itself. Usual causes of chronic renal failure are the biggies. Diabetes, that's what we see chronic renal failure most. That's why, and so diabetes and renal failure are married together. First of all, you've got microangiopathic disease, you've small vessel disease at the glomerulus. The glomerulus is basically killed off, and they develop chronic renal failure. If you have diabetes and chronic renal failure, you're an automatic entry into the Medicare system in the United States, even if you're 30 years old. And once you get into that, you're automatically entered into the dialysis program if you require it, and then you're automatically ready, you're qualified to get a renal transplant. Systemic hypertension, also associated with renal failure, but usually diabetes mellitus and systemic hypertension will go together. Atherosclerosis, same difference. Then there's some other causes of it. Tubular cell injury from nephrotoxins, from analgesic. Now, chronic overuse of things like ibuprofen can cause tubular cell injury and chronic renal failure. So we're not advising people to take high doses of. It's also associated, incidentally, with increase in stroke and cardiac disease too. So stones, chronic stone obstruction, recurring stones. I'll show you a picture of a couple of interesting ones. Obstruction at the bladder, neck, or urethra from chronic prostate infection. So one of the bad things with prostates is just benign prostatic hypertrophy can decrease urine flow. You can have so much resistance to urine flow, the increased bladder pressure, that ends up ultimately backing up and getting increased pressure in the urethra, in the ureters. The ureters swell to a certain size, and then you have this chronic pressure on the collection system, which backs up and is reflected as increased tubular pressure, and ultimately can damage the tubes. Interstitial injury, mostly infection, pyelonephritis. When you have chronic kidney impairment, you cannot maintain your normal blood volume and normal pH and electrolytes. So you have increased sodium, increased water, increased potassium retention. That then is reflected as increased blood pressure. Normally your kidney tries to retain glucose for you. When your kidney function is damaged, you lose glucose. You can't reabsorb glucose. So they lose more glucose, and then potassium follows the glucose. So although their potassium level, they may be retaining potassium at one level of the nephron and tube, they're losing potassium through the tube to go along with the glucose. So their total body potassium levels begin to deplete. Urea begins to build up because urea is selectively excreted and glucose is retained. So when you lose glucose, you selectively retain the urea, and that builds up in your body. So your BUN rises and your creatinine level rises, and that indicates that you have chronic renal failure. Blood pressure, arterial blood pressure, this whole renin-angiotensin loop is messed up, and you end up with hypertension caused by too much angiotensin, too much aldosterone, and you're retaining too much fluid and water. So it's a perfect storm. And then almost all your renal failure, chronic renal failure patients have chronic anemia because that erythropoietin connection is knocked out. So, in assessing the patient, we try to differentiate between chronic and acute problems. Your focused history and physical exam concentrated on GI complaints or complaints of pain, where it is changes in mental status. During your physical exam, you may determine that they have pain and palpation of the kidney, pain and palpation over the ureter. Uremic frost, you get too much urea, it's excreted in sweat, basically, and they'll get what's called a uremic frost, which is get a little sweat along your upper lip, but then the urea crystallizes out and it looks like frost. You can also see it under the armpit, but we don't generally examine that. That's a very complicated, messy slide, and I'm not going to worry about that one either. Now, immediate management, chronic renal failure or acute renal failure for that matter, monitor ABCs, IV access, don't want to over fluid load them, and they're going to be hypertensive anyway. Vital signs and cardiac rhythm. So they may be complaining of headache, edema. They may be weak from mild anemia, probably have increased blood pressure. And they're not able to concentrate their urine. They're not, they may have signs and symptoms of hyperglycemia. They may have signs and symptoms of hyperkalemia. Renal stones, these are bad. This is called the staghorn calculus. This stone has concentrated and filled up the entire renal pelvis, and that's, as you can see, looking at this is not a kidney that was in good shape and didn't survive the autopsy table. And because none of the urine can get out past this stone, you've got chronic pressure and ischemia of this entire kidney, and basically the kidney gets killed by that chronic back pressure. Stones occur because there's too much salt dissolved. Remember the old experiment we did in grade school where you would make a super salt solution and then put one little crystal in it, and the whole thing will crystallize out. That's what happens with too much concentrated urine, too much concentrated salts. The usual culprit is calcium salts. However, uric acid can occur in people who have gout. Cystine crystals can occur, and struvite, which is another type of salt. You can also get bilirubin stones. Focus history what they're going to tell you is they have usually severe pain in one flank, starts in the flank, and then as the stone moves down through the ureter, the pain moves from the flank down into the abdomen and then down into the groin. And it just follows. You can tell there are three places that a stone hangs up. Stone hangs up at the beginning of the collection system at the renal, where the renal pelvis joins with the ureter. That's a narrow spot. Then the next place it hangs up is as the ureter goes over the bend of the pelvic brim. There's a kink at that point, anatomically. That's a narrow spot. That's where they hang up. And then it's a narrow spot as the ureter goes into the bladder. So you get three places where the stone hangs up, and you can follow the progression of the stone by where the person's telling you they're hurting. Nowadays, people, if they get one renal stone, they're going to get them again. So usually they have a history of calculi, or first time severe flank pain or pain radiating into the abdomen from the flank, associated with frequent urination, sometimes with hematuria because the stone is ragged and it scrapes the ureter, so you get a little blood in the urine. It's usually described as the worst pain anybody's had. Patient, because of that pain, is tachycardic, pale, cool, moist skin. They're diaphoretic. It really hurts. And they will not be able to find a position of comfort. Often like to move around trying to find a position of comfort. So let them, if they find a position they're comfortable in, let them. Check their ABCs, of course. A fluid bolus will help often to move this down. Make it hurt more, but it'll move that stone along. What you're trying to do is just get a head of pressure to push that stone down. They are nauseated and vomiting, treat them for that. Pain medication, don't hesitate to use some fentanyl on them. They will probably not do, a big guy will probably not do much improved by 50 mics. They will probably need 100 mics to make them feel better. Don't worry if you think that, don't withhold pain medication if you think it could be a stone or they could be drug seeking. That's not your choice. That's not your decision. Now, if they have a history of chronic drug abuse that you already know about, then you can pretty well bet on that one. Okay, testicular torsion occurs mostly in adolescence. Can occur in young, in 7, 8-year-olds, but mostly in adolescents. And what happens is that the testis is poorly fixed into the scrotum. In some people, it becomes very mobile and it can twist on itself. When it twists, it puts a kink in the blood supply and the nerve, but mostly the kink in the blood supply, and that causes ischemia to occur. And if it's a complete twist and you completely cut off the blood flow, then that testis has about a 2 to 4 hour lifespan. So we try to unkink them, untwist them. And generally we have to take them to surgery, untwist it, and then tack the testis down so it can't do that again, can't rotate. Now, sometimes people will get intermittent. They'll have had this episode before. They'll say, yeah, I had something like this a couple of weeks ago. Now, and then it unkinked all by itself. Can occur during sleep. Can occur during athletic activity. Can happen from a direct blow or trauma that causes the cremaster muscle to go into a spasm, which does the twist. It's an emergency. Now, the same thing can occur in women. They can twist an ovary. It's really uncommon, but it can happen. Obviously, the patient is going to be pain, nausea, vomiting. You're treating you treat them for pain, you treat them for nausea, vomiting. Transport them. They're going to be transported. Preferentially, they'll probably feel better laying on it. It actually helps to elevate the testis a little bit. That helps to decrease discomfort. Urinary tract infections, increased risk in females, increased risk just because the urethra is shorter, increased risk in catheterized patients. Basically, urinary tract infections come as either infection of the urethra, so it's urethritis, cystitis, bladder infection, prostatitis, infection of the prostate, pyelonephritis, infection of the kidney. Most of the urinary tract infections we see are community acquired. In women, they'll be caused by normal bacteria, usually the bacteria that live in the vagina. So most of the time it's going a little bit of E. coli, sometimes a little Shigella, little gram-negative kind of bacteria. Nosocomial infections, the ones that we cause, in other words, are the ones that happen in chronically catheterized patients. So little old people in nursing homes who have a catheter. Every catheterized patient has a urinary tract infection. Now, most of the time you get along, chronically catheterized. Most of the time they're not causing symptoms, because most of the time we can tolerate our own bacteria. Sometimes they'll cause infection. Most of your little old people who are in nursing homes who present to you with changes in mental status, and you say, I think this is probably sepsis. About half of those people are urosepsis, and when you walk in the room because they smell like it. And the other half are pneumonias causing sepsis. They may have abdominal pain. Cystitis and urethritis cause frequent painful urination. infection of the kidney doesn't cause painful urination, but you often have fever and a pain due to pressure and inflammation over the kidney itself. Burning sensation associated with urination it means bladder infection or urethritis cystitis, and trouble starting and trouble continuing voiding because it hurts. Similar past episodes, etc. Physical exam, urinary tract infection, the patient usually restless, uncomfortable. It's a somatic pain, so it's not usually localizable, except that they've got pressure over the kidney. They may have a fever, and depending on how much pain they have, their vital sign. Now, anyone who has a pyelonephritis, a kidney infection, that is most of those patients we admit to the hospital for IV antibiotics and supportive care for at least 24 hours. Then they can go on orals. But most people with pyelonephritis, that's a major infection. We treat that very seriously. Obviously, you treat what you find. Okay, a couple quick things about ALPS. We're still in the ALPS thing. We're still going along. ALPS, all non-traumatic, out-of-hospital cardiac arrests, vascular access has to be established. You can have an IV or an IO. It's persisting or recurring VFib or VTAC after one or more shocks. Can't use any open label amiodarone or lidocaine. And obviously we have protected populations. That hasn't changed. What counts as a shock? Any shock that occurs except for an ICD shock. So any ROC agency, any BLS AED shock, any public access shock, that counts as your first or second shock. We had a case just a couple of weeks ago where they got 2 shocks by a PAD, a public access defibrillator, before they even arrived. So immediately you could go into the ALPS care. So any shock, because an AED will only deliver a shock to VFib or pulsus VTAC. So confirmed VFib, pulsus VTAC, any time after the first shock. After the first shock, think ROC. So antiarrhythmic, anytime you think I'm going to give an antiarrhythmic drug, then you give the ALPS drug. It's only about 17% of your codes. The drugs have to be given as soon as possible. We want them in within 10 minutes. You guys are all getting them in. When you give them, you're getting them in just fine. If you have ROSC and you've given an ALPS for the first 2 syringes, and you have VFib recurring, you immediately go into the ALPS thing again, and you can give that second dose after you give a shock, give the second dose of ALPS treatment. So anytime you're recurring, you go through the entire thing. If you've given all the ALPS drug, you can't use Lido, you can't use Amio if they stay in VFib, VTAC, but you can use MAG, and you can always use epinephrine recurring all the time too. Got to use the clear link. If you break a syringe, they're automatically out of the ALPS thing. You do enroll them, you still, because you started them, you have to call, and then you just say, we got a broken syringe, so you can go at that point to your standard ACLS treatment. When you enroll a patient, you call that number. It's written down for you, don't have to remember it. Document time and timestamp when you gave the drug, the barcode, the CPR process file. Document whose thing you're using, whose monitor you're using too. We need to know that. Sometimes it's hard to sort it out. Oh, wait a minute, I don't want to do this one. I'm going to close this down first. Well, no, we'll go to the EMS case reviews.
You want to do slides before you do that?
Yeah, I do.
Okay.
Let me, I guess I can just close this, right? No, I want to minimize it. There we go. Okay, I'm going to talk really quickly about another study that we're back into doing again. It's we were doing this a long time ago. It really only affects transport units, but the rest of you need to know about it too. This is the SUD study, sudden unexpected death study. The purpose of this has been going on now for, I'd say almost 15 years now. It's one of the things to investigate sudden cardiac arrest patients by comparing not only the clinical but laboratory findings, and particularly the person who's running this, Sumit Chugh, is a cardiac geneticist, basically. And he's looking at finding genetic markers in persons who've had sudden unexpected cardiac arrest, whether they survive or not from your treatment. Anyone who's had sudden cardiac arrest, there are a certain number of genetic markers that are showing up that we think we'll be able to predict what your risk factors are, maybe even when you're a little kid. So this is the point of the study, is to find those genetic factors, find what factors predispose people to this. So if you have a presumed sudden cardiac death, we look at the clinical records, autopsies, and also look at phenotyping, or the genetic markers, and establish ultimately a genome and tissue bank to continue doing this epidemiologic research. Now, originally, over this last almost 12 years now, we've collected about 3,500 cases from Multnomah, Clackamas, Clark County. The point, and what we were having AMR do mostly, because they were the primary transport aid, is that sometime in that cardiac arrest, treating that cardiac arrest, as long as you didn't interfere with the actual treating of the cardiac arrest itself, your CPR, etc., was to draw a blood sample. So from this, we have actually done several papers and stuff already. And Sumit Chugh has he's done a lot of different journal work and presented a lot of things, and he's now out of, he left Oregon Health Sciences and is down at Cedars-Sinai in Los Angeles, where they basically give him more money to do the research, so he has a bigger laboratory. And we're wanting to get into doing some more. I was co-author on a couple of the studies already too. So what we need is blood samples, and he needs more blood samples to develop, to further define some of this. I think we're right at the edge. He thinks we're right at the edge of making a couple of major breakthroughs. So we will have blood samples collected again from transporting. There's no point in putting the blood sample collecting thing on fire, because first responders, unless they're also transporting, won't have the opportunity to bring it in. So you need to collect the blood sample on anybody who's got a cardiac arrest, whether they survive or not in trauma, not in violent death, not in overdose. So with sudden, unexpected cardiac death. as soon as possible after starting an IV. Never interfere with resuscitation. And this is all that's going to need to be carried on the AMR cruise primarily, which is one blood tube and the blood drawing equipment. Now, most of that if you start an IV, you could put that immediately onto the thing, collect a sample before you hook up an IV. Now, if that gets in the way of doing drug administration or ALP study, you can't draw the blood at that time. You want to draw the blood when you're not going to interfere with. And I don't necessarily want you to try to draw blood from a site other than an IV. You don't need much blood, so you can get a small amount. Then you label the tube with the name, EMS number, date of service. If you have a hospital face sheet with you, fine. Place there's a little baggie, and you just keep it in the fridge. In the ambulance cooler, and then drop in the fridge at headquarters. Your normal information is just your pre-hospital care report, history, previous medical history. It'd be nice if we have the code summary, because then we'll identify the presenting rhythm. Of course, you're going to turn the code summary in anyway. All your PCO files are going to go to ROC. We correspond with ROC, so we can get that back from them. You're also sending me the PCO so that I have that PCO. So we're trying to identify the high-risk patients, and then ultimately, if we identified that you or one of your kids had a genetic marker for sudden cardiac death, for VFib, sudden cardiac death, we would probably recommend right off the bat that maybe you consider having an implantable defibrillator. And that doesn't sound as scary as it used to be, because there's a couple of new implantable defibrillators that don't require venous access. They basically can defibrillate without having pacer wires. So AEDs, home defibrillators, etc., would be, are one of the things you might have in your home instead. Now you can buy an AED from Costco, it's cheap. So we're looking at genetic markers and then medications that might be contributing to sudden cardiac death, because we're evaluating the patient's history and their medication history. There may be new therapies for PEA coming out of this. And really importantly, how ethnicity and sudden cardiac death are related. He has quite a bit of genetic information already on African Americans that indicates some significant connections there. So we're going to be starting this up again. I think John Griffith is going to be taking it, in servicing all the AMR crews. I want you all to know about it, though. And then I think Camus and North Country are considering coming on with this too. Okay. Case reviews. Okay, this is our new little confidentiality statement. You can talk among yourselves here, but you're not supposed to take this out to parties outside of this group, okay? Now, even though we do redact all the stuff so you don't know the names of these patients. Okay, first patient, 58-year-old male, supine in bed. Caregiver states patient diagnosed with renal failure. First hint, has been getting lab values weekly, potassium 7.1, EMS notified for transfer. Says patient's been bradycardic for past week. and he was on amlodipine, but was stopped now. Complaints of weakness, no other complaints. En route, medical center contacting advised hyperkalemia protocol appropriate. Well, now, why did you call to get hyperkalemia protocol? You have it in your orders already. So, patient has blood pressure of 92/60. Get some calcium chloride. What else does the patient need? And this is, by the way, is his 12 lead. Well, we knew that he had a potassium earlier of 7.1 because that blood was drawn, and then they called him and said he's got a potassium. So what do you think his potassium is now? Do you see any peak T waves? I don't. You see any P waves? Well, I can't. I have to lie about it, so I'm not going to say I do. You've got a long, if you do, you have a super long PR interval, and you've got flat P waves and a few leads. The rest, you can't really see them. The QRS is widening. The T wave is flattening. So it's probably in the 7.5 to 8 range. Indeed, after his treatment, he got what? He got calcium. What else should he have gotten? Bicarb. Why didn't he get bicarb? Because you didn't have it. Okay. Ask the fire people, because Vancouver Fire still has bicarbonate. Camas, I think, has bicarbonate. That shouldn't be a problem. So now, I don't recall, let me just see. I don't recall if he got albuterol or, yeah, he got albuterol. So albuterol is good for 0.5. Calcium would probably be gone by the time he got to the hospital without anything. Of course, he didn't have insulin. So he didn't get insulin and glucose. And he could have got some Lasix, but he didn't get any Lasix either. So when he got to the hospital, he had a potassium of 6.8. So it did come down nicely, quite a bit from he was probably at about 7.5 to start with. So it came down, and then he got the rest of the treatment that he needed. He was not on dialysis. Now, the next patient is complaining of vomiting, chills, hasn't been able to take his oral medications, states his blood glucose has been reading high, so we know he's got diabetes. His last dialysis was 2 days ago and is due again today. States previous episode of the same requiring admission to the ICU for DKA and hyperkalemia. Says he's been producing urine, but not very much. Past history, IDDM, renal disease, dialysis, hypertension, hyperlipidemia. All the things I said contributed to chronic renal failure. Well, he got treated for nausea. His blood pressure is 220. Pulse rate's 103. Glucose abnormally high. He got some chest pains where they gave him a little nitroglycerin. Blood pressure stays at 228 now. I got a vascular access. And there was a discussion between, and then he's got this 12 lead. Now, before you get too excited, this is, so there was a discussion between the medics about whether they'd treat him for hyperkalemia between fire and transport. It was decided that they would not treat for hyperkalemia, which is fine, except for all the wrong reasons. It was the right decision, but the wrong reasons. And the reasons given were that, well, the doctors at the ER they like to see what the potassium is before we do any messing around. Not true. Not true. I want to know the name of any ER doc who tells you not to treat what you think is hyperkalemia as hyperkalemia. You can always treat with albuterol, which is pretty mellow, pretty easy, and very little side effect. Then he said, well, there's no reason to start down the treatment path because I could give him the calcium, but we don't have any bicarbonate. Well, all you have to do is ask the fire again for whether they've got bicarbonate. You can always still treat with albuterol. That's not a big deal. Well, at any rate, so they said, well, gee, this is pretty impressive looking peak T waves, right? Only problem is, you see them anyplace else other than these two leads? No, you don't. And all of a sudden, this is kind of a nice normal. This is not a big, exciting T wave. It's not very peaked. There's no peak T waves in these leads. So you've only got peaked T waves, big T waves in these two. And look at the size of the QRSs in these leads too. You just have lots of big deflections. So you just have big. So this turns out, in actual fact, the potassium in this person was only 4.2, which is normal. He just had hyperglycemia, wasn't DKA, and it wasn't hyperkalemia at this point. He'd only hit his dialysis a couple of days before, and it apparently worked pretty well. So he got treated for his hyperglycemia, and that's about it. Okay. Person awakens at 5:30 with chest pain, 10 of 10, left side of chest, non-radiating, sharp, constant pain. Sharp pain doesn't sound, this is not an old person, this is not a young person. Sharp pain doesn't really sound terribly cardiac often. No nausea and vomiting, no shortness of breath. Felt well for 2 weeks with cough, weakness. Chest tender to the left side with palpation, lungs are clear. Everything else, he was brought in as a STEMI alert based on this 12 lead. Which appears to be some ST segment elevation in V1, maybe in V2, not very, and this baseline is a little bit wandering here too, so I don't know that I would trust this one at all. So these two, not too impressive. This is not elevated, and this is maybe, so I think it's a machine error. This is not elevated and significantly, and this is possibly elevated. So at any rate, it was called as a STEMI. Happily, it was during the middle of the day. I think it was about, early in the morning, actually 8:30. So the cath lab was already there. So it wasn't that they had to bring him in. And it was a weekday, so they were there anyway. So, and the cardiologist, the ER doc and the cardiologist, when they got a better tracing in the ED, this is just an overread, which I don't fault anybody for, but just be cautious of these. I think maybe a second 12 lead would have been nice after you got the person settled in the ED, in the rig, and see what this looks like. But this was thought to be simple costochondritis, reproducible chest pain from the rib junction, sharp, constant pain. Enzymes were negative, and his 12 lead in the ED was perfectly unremarkable. "71-year-old male with dizziness, states history of VTAC." How often do you get that? Usually self-resolving. Past history of MI and heart surgery, denies chest pain, shortness of breath, no nausea, vomiting, no distress, runs of VTAC occurring. This is what's quite impressive. This is a LifePak 15. Obviously, it doesn't simultaneously record all 12, but within this, we have runs of VTAC and runs of and then normal sinus rhythm. So the patient is treated, and this is kind of impressive, coming in, coming out, coming in, coming out. And so he was treated fatal. Keep blowing that one. With amiodarone, how much amiodarone do you give for someone who's having stable VTAC? 150, not 300. Give it over how long?
10 minutes.
10 minutes, it says. I bet it didn't really take 10 minutes, but so they're IV dripped in there, and the patient had settled down. And now, interesting enough, this guy went on the basis of this run of VTAC. They took him back to the cath lab ultimately and looked to see, and he did have some structural lesion, and they stented it. If he had not had any structural lesion, he probably would have qualified for internal defibrillator. Once you have a structural lesion, you get out of that. Okay, so next month, same time, same station. I think we're doing some psych stuff and some update and a few things like that. Anybody got any questions, any thoughts? Okay. Stock tips, yeah. Buy high,